Hello, this is Kim Jong-il. Today, we will look at the diagnosis and treatment of rotated teeth. The first part is about the treatment of rotated anterior teeth. Andrews said that in order to achieve a normal occlusion in 6 keys, normal occlusion, there must be no rotated teeth. Rotated teeth can be divided into 2 main categories as rotated posterior or premolar and rotated incisors. Rotated molars or premolars take up more space than normal teeth. On the other hand, it can be seen that the rotated incisors have less space than normal teeth. Rotation means that the tooth changes according to the long axis of the tooth. We use the terms mesial rotation to mean mesial in rotation, and distal rotation to mean mesial out rotation. Resolving rotation is called derotation. Because rotated tooth is closely associated with relapse, we should consider. There are 2 main types of crowding. It can be divided into horizontal displacement, which represents horizontal tooth movement, and vertical displacement, which represents vertical tooth movement, as seen from the occlusal plane. The palatal displacement and slightly rotated incisors belong to the horizontal displacement. Dr. Little used an irregularity index when evaluating rotated teeth. This is especially used when evaluating the crowding of the mandibular 6 anterior teeth. In the mandibular 6 anterior teeth, the contact points of each tooth must coincide with each other. But if there is crowding, the contact points do not coincide. In the irregularity index, the distance between non-matching contact points is measured and evaluated. Which teeth are rotated most frequently? All teeth can be rotated, but among them, the first and second premolar teeth of the mandible, central and lateral incisors of the maxilla, the first and second molars are rotated most frequently. Let's summarize the terms. There are winging teeth and overlapped incisors. When the distal margin of the maxillary central incisor is located toward the labial side, it is called winging teeth. The upper central incisors overlap as shown in the picture is called overlapped incisors. Overlapped incisors often show attrition. If attrition is observed, it is most likely that the tooth axes between the upper central incisors are not parallel. In the case of these overlapped incisors, there is a high possibility that a black triangle will appear between central incisors after the teeth are aligned. This can be resolved through reproximation after treatment. Black triangles may develop during treatment, but can be resolved after treatment. If you look at the rotated anterior teeth, you can see that there is not enough space. In order to properly align the rotated teeth caused by lack of space, you need to create the space. In general, 1 millimeter of derotation means 1 millimeter of space is required. There are 2 main ways to gain space. The first is to use superelastic arch wire, and the second is to secure space and then align it. When teeth are rotated, many orthodontists use superelastic arch wire to secure space. Using superelastic arch wire is quite convenient for doctors. However, undesirable forces can be applied at this time, resulting in unwanted tooth movement. In the picture, a tooth 11 has been meshily rotated. We want to move the tooth with mesial side of tooth 11 outward and the distal side of tooth 11 inward. At the same time, a reaction may occur on teeth 12 and 21. What reaction will happen? Tooth 21 will rotate mesially, and the mesial margin of tooth 12 will rotate distally. To solve the rotation teeth, you can use the knee-tie arch wire as A, or you can also use overlay arch wire on the main arch wire as B. I recommend putting OCS on the main arch wire to make a space while using overlay knee-tie wire like C. Rotated teeth require attention to bracket bonding as well. Let's compare A and B. Which bonding is better? When viewed from the front, the clinical crown width may look larger than real size, like A. However, in the case of a rotated tooth, the appearance of the labial clinical crown should be checked as shown in B. After closely check the labial side, it's good to bond the bracket like B. What does this mean? Attaching bracket like A increases the likelihood that the bracket will be located slightly more distal to the center. Like B, it is better to attach the bracket slightly more to the mesial side than the long axis of the clinical crown. Here are some things to keep in mind when treating a rotated tooth. 1. Couple force system. 2. Rotation wedge. 3. Rotation loop. 4. Spring retainer. The first is the couple force system. Couple force system means that two parallel forces exert forces in different directions. If possible, it is recommended that the magnitude of the force is the same each other. Like this, attach a bracket to the buccal side and a lingual button to the lingual side. Derotation of the rotated tooth can be done easily by applying force in different directions on the buccal and lingual sides. At this time, energy chain is mainly used. Let's look at a case. Tooth 35 is mesial rotated. Use the power chain by attaching lingual buttons on the lingual surface of the teeth, 35 and 34. And an attached lingual button on the buccal surface of the teeth, 35, and used a power chain from the tooth 35 to the tooth 36. Rotated teeth can be derotated through this couple force system. At this time, let's think about where to attach the lingual button. A couple force system is used to derotate the rotated teeth. The lingual side should be rotated mesially, and the buccal side should be rotated distally. You can attach a lingual button like B, C, or D. It is most ideal to attach it like B, but it is difficult to use an energy chain. In clinical practice, it is recommended to attach it like C. D is easy to bond, but the acting force is weak. It can be divided into cases where there is a rotated tooth in the posterior and anterior. At this time, full bonding or strategic bonding can be performed. In Mio, it is recommended to attach the brackets strategically. In the case of full bonding, it is very difficult to solve crowding, and it is not easy to solve mesially rotated teeth. An important factor when attaching a bracket to a rotated tooth is whether it can be attached in the desired position. If you can attach the brackets to the teeth in place, it's great, but if that's not the case, it's better not to attach the brackets at first. I also make a lot of mistakes. As shown in the top picture, if there is a minor crowding, it is okay to do full bonding. Teeth 31 and 42 are slightly rotated as shown in the middle picture. It takes a long time to derotate the rotated teeth when the initial full bonding is performed, and there is a high possibility of relapse. If you can't attach the bracket in place, it is better to use OCS to make space first. and then attach the bracket. In this patient, you can see crowding in the anterior, canine, and premolar areas of the mandible. There are also meshally rotated teeth and distally rotated teeth. I should not have done full bonding at that time, but I did it in the end. As a result, it became difficult to control tooth 33. In this case, it would much better to use an open coil spring on teeth 32 and 33 area because tooth 31 was rotated. Then the rotated tooth is derotated and a space is created. Another way is to not attach brackets first to teeth 31 and 33 with crowding. In other words, making a space by using an open coil spring on area of tooth 31 as shown in the photo. Attach the bracket to the tooth 31 and make a space by using an open coil spring on the tooth 33 area. And then attach a lingual button to the tooth 33, and you will be able to easily derotate it by couple force system. In cases with rotated teeth, it is recommended to use a couple force system. In order for the couple force system to be effective, bracket must be strategically attached to the teeth. For teeth with crowding, do not attach the brackets but use an open coil spring to make a space. Crowding can be solved relatively easily by attaching lingual buttons to the labial and lingual sides of the tooth and using an energy chain. Then re-leveling the teeth again with 014 niti and use rotation wedges if necessary. This patient had a mandibular second premolar extracted. In the case of extraction of the mandibular second premolar, a bracket is not attached to the canine at the beginning of treatment. This is a strategic bonding, attaching brackets to the mandibular teeth 1, 2, 4, and 6. Also, make a space first by using an open coil spring without attaching a bracket to the area where there is crowding in the mandible. Then, after the 8 teeth are aligned, not only can the rotated teeth be easily derotated, but the space is also easily closed. Let's look at this patient. Crowding is shown on tooth 41. Without full bonding, open coil springs were used to make spaces and then brackets were attached. The photo below is a case of mandibular second premolar extraction. The mandible teeth 33 and 43 will be bracketed later. The mandible teeth 33 and 43 will be bracketed later. On the left side of the mandible, brackets were attached to teeth 1, 2, 4, and 6. On the right side, tooth 42 is crowded, so it is better to attach a bracket to tooth 42 later. Push back the tooth 44 first, and then attach brackets to the tooth 43 and to the tooth 42 at the same time, so you can resolve a rotated tooth more easily. You can also use a rotation wedge when resolving rotated tooth. The one side of the rotation wedge is thick. As shown in the picture, if you engage the rotation wedge to the bracket with a Weingart utility plier, the thick portion of the rotation wedge derotates the rotated tooth to the lingual side or palatal side. Then, the mesial side is rotated to the labial, making it easier to resolve the rotated teeth. To control the rotated, use the open coil spring first to make a space, and pull it with a ligature wire as shown in Figure A. Then apply niti overlay while maintaining the open coil spring as shown in Figure B. If rotation is not severe, directly apply niti overlay without traction as shown in Figure C. In most cases, the rotated tooth will be resolved by bracketing in the correct position. If some of the problems are not resolved, derotation is performed using a rotation wedge as shown in Figure D. Rotation wedge should be put on the part which needs to move to the lingual side or palate side. Then the mesial side will be rotated towards the labial side and then put in the leveling arch wire. Look at this case. There is crowding in tooth 12. Push the canine back using an open coil spring and attach the bracket to the tooth 12 and then traction it. The tooth 12 will jumps out, so you can align the teeth easily. Then move the maxillary canine posteriorly and move the mandible posteriorly. Be careful when engaging the rotation wedge. In the case of mesial rotation, engage the rotation wedge on the distal wing of the bracket. Tooth 12 is rotated. It is not easy to attach the bracket in place, so after strategic bonding, an open coil spring is used to make a space. At this time, the teeth move slightly backward by the transseptal fiber. If there is space to attach the bracket in place, attach it and align the teeth. If the mesial rotation remains as shown in the photo, you can use the rotation wedge to move the distal side of the labial of the tooth to the palatal side. In the photo, there is enough interbracket distance between the central and lateral incisors in the maxilla. On the other hand, when full bonding is performed on the mandible, the interbracket distance is insufficient. Use an open coil spring between teeth 11 and 12 to resolve the rotated tooth 12. There is a high possibility that the mesial side of the tooth 12 will be distally out. The length of the open coil spring used at this time is usually half of the one bracket width added. Through this process, the mesial rotation of the maxillary, lateral, and central incisors can be easily resolved. This is a case with winged teeth. When the upper central incisors are winged like this, if you attach the bracket to only one tooth, it will be non-aesthetic, so attach it both incisors. The size of the maxillary central incisor is large, so you can attach brackets at the same time. After attaching the bracket, insert an open coil spring with a small amount between the central incisors. A small amount means add half the length of the bracket width to the original interbracket distance. So what will happen? As the distal of the winged teeth goes inside, crowding can be solved. You can also use a rotation loop. The rotation loop can be made through wire bending. If the wire bending is wrong, the loop can impinge on gingiva, but the effect is better. Rotation loop is facing outward for mesial out, and the loop direction is different for distal in. So, a loop in which one direction is out and the other direction is in. A mesial rotated tooth can be seen a lot in the canine area. In most cases, the canine is mesially rotated due to the rotated lateral incisor. Or, it is possible to cause mesial rotation due to incorrect bracket position on the canine. Let's look at the long axis and bracket position of this patient's tooth 13. The bracket position is located slightly distal side. If the bracket is located on the distal side, the possibility of mesial rotation increases while leveling teeth. Tooth 43 is also rotated mesially. Since the bracket is located slightly distal to the long axis of the tooth 43 was mesial in rotation while leveling. When initially bonding the brackets, if the teeth are rotated, it is recommended to attach them to the mesial side slightly than the center as an overcorrection concept. It is important to accurate bracket placement. Again, it is recommended to bracket bonding the rotated teeth slightly to the mesial side of the tooth's long axis. You can also engage the rotation wedge on the distal bracket wing. Alternatively, you can use a rotation loop. In particular, when treating rotated mandibular canines, you should check the freedom between upper and lower canines. Without maxillary canines in freedom, it would be quite difficult to solve the problem. The maxillary canine should be resolved first, and then the mesial rotated mandibular canine should be treated. This patient has crowding on tooth 41. The bracket may be attached in place, but it will not be easy to make a space. So it is better to first use open coil spring to get enough space, and then attach a bracket to align the teeth. If the timing of the crowding treatment of anterior teeth is delayed, you will experience difficulties in the finishing stage. After treatment, for teeth that are not severely crowded, a spring retainer can be used. Make a setup model of tooth 41 with crowding, align it, and add resin to the labial and lingual sides. Since the resin part touches the mesial in the labial side and the distal part in the lingual side, force is applied to both sides to derotate the rotated teeth. Spring retainers are used in cases of minor relapse after treatment. How to treat a rotated anterior tooth. Please remember the following: 1. Couple force system. 2. Rotation wedge. 3. Rotation loop. 4. Spring retainer. Thank you for watching.